All right. I get to back clean up talking about tachycardia. I love it. This is awesome. Good lectures today, though, guys. We learned about butt chugging, right? We learned about tampon use with alcohol consumption. I'm going to choose the more conservative route, to be honest with you. But hey, ideas are ideas. If you guys roll up on scene with me for excited delirium and you guess my weight to be 150 pounds, you're going to severely underdose me. Okay, I'm just saying that. All right. So good points that Dr. Bradley mentioned about guesstimating weight, especially with medications. I always like starting out with you guys just to kind of do a little pulse check, pardon the pun, as far as like how things are going at desert. A lot of times, it's like I use this time as like an opportunity to get you all in one room, and I'll do this tomorrow too. Get you all in one room, kind of to see kind of where we're at as far as traumas go, where we're at as far as offloads go, where we're at as far as like your interaction with staff. Again, a lot of my job, doing cases and doing CME stuff is going to meetings, which I love those, is kind of reorienting our staff as far as giving them a picture, a window through your eyes, right? Trying to paint the picture for them of your life is completely different than their life, right? And a lot of the complaints that I get of, why didn't EMS do this? Why didn't they do that? Blah, 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 right? Try to kind of paint the picture. I'm like, you've never tubed somebody on a family room floor with a chihuahua biting at your ankle, right? So there's that orientation there. So a lot of my job is that, but also kind of being your voice with the hospital, right? So kind of passing on your concerns, your experience to the powers that be, and no promises. I'm no one special, right? They may or may not listen to me, but at least your voice gets heard to the right people. So that being said, open target. How are we doing at Desert? Any comments, questions, concerns, struggles? We ain't doing that great. So either you guys are already asleep thinking about tachycardia, right? Or something's happening. So how about offloads? How are we doing with offloads? Any issues with being stuck in that EMS hallway for a while? Or are they kind of, yes, sir? Okay. Okay. So no stretcher at all, just an empty room? Okay. You got to wait a long time before someone comes like, okay. Like, how do you get somebody to the room? Like, do you have to send a crew member to go find somebody to get a nurse to get a report from you? Or does somebody eventually show up? Okay. All right. I'll talk to them about that. Okay. Because usually once they because especially if you guys patch ahead, right? They already pre-assign a room to you guys. Yeah, I mean, so unless the nurse is hung up doing something else, but again, they have other people, so they can help you guys out. I'll talk to them about that. I'll talk to Ann about that. Yeah. Anything else? Oh, that was easy. Jeez. Okay. All right. So now it's nap time, folks. Okay. All right. Many flavors of tachycardia. So I brought this up, and the good thing about tachycardia, right? And again, in our lives, we like to keep things simple, right? So in our lives, the treatment for tachycardia is pretty cut and dry, pretty basic, right? In fact, of all the slides that I have on here, I got one slide on treatment, right? Because we already know the treatment, right? We have it in our protocols. The reason why I wanted to talk about it, right, is again, there's different things that could cause tachycardia, right? And in our line of work, it's not uncommon for us to encounter a situation where we think one thing and then we kind of go down a completely different rabbit hole based on our encounter with the patient and the ride into the hospital. So that it's that anticipation of badness, right? And knowing, okay, what might I be dealing with, right? To help me kind of guide what's going to happen 2 minutes down the road. What's going to happen as we're pulling up into the hospital? Because a lot of times you guys will patch in with one story, right? Because that's that slice of time. And then you show up with the different story, and then everybody's pissed off at you, right? And they're yelling at you, why'd you do this? Why did you get? But again, they don't understand that things change, especially in your line of work, especially in acute care. Things change. So if we kind of know or have at least a basic understanding of what we're dealing with, right, and what's causing the problem that we're facing, right, sometimes we can anticipate that badness. And so that was my intention for talking about the tachycardia. So again, we'll talk about the different causes of tachycardia and tachydysrhythmias. Again, tachycardia, so cardiovascular diseases and play a key role in that. Talk about that and how they influence tachycardia. We'll talk about the different tachycardia syndromes. You're gonna love that one. And then, like I said, for treatment in our world, especially in your world, it's pretty cut and dry. You know what I mean? We just got to break it down to some basic, simple components, follow your algorithms, right? Get them to definitive care. So what is tachycardia? So anything with a heart rate greater than 100, tachycardia, right? Most common abnormal vital sign. About 684,000 people come to the ER or call you guys with palpitations, right? So palpitations could mean anything. Palpitations is a subjective experience, right? So what one person feels is a palpitation may be different from another. However, right, tachycardia alone, right, especially in the setting of any underlying disease, right, increases the probability and likelihood of them having bad outcome or a poor prognosis from their underlying disease, just looking at tachycardia alone. And then they did this one study in American Journal of Cardiology. Men with a resting heart rate of greater than 90, I could tell you about the amount of Mountain Dew that I drink at work, right? I probably fall into that one, to that group. It has a direct increase in their general morbidity and mortality, right? So again, tachycardia is a key thing in patients' general health and well-being. So I'm going to nail this thing home to you guys because we're dealing with tachycardia, we're dealing with the heart, we're dealing with what the heart spits out for us, right? So cardiac output, right? That's what we care about the heart, right? So cardiac output, what the heart does for the body, is directly related to the heart rate, right? We'll talk about tachycardia, right? And the stroke volume. So we'll talk about the different influencers of that cardiac output, right? Because that's what we care about, right? That's what we care about as far as perfusion to vital organs. So neurological causes tachycardia. So again, we have our sympathetic nervous system, your fight or flight response. That is centered around a series of ganglion in our central chest called your thoracolumbar ganglion. In that ganglion, you have nerves that directly innervate to the various target organs, and they exert their effect on the organ. Again, the fight or flight type of response, sympathetic nervous system. Of note, right, again, ones that we really care about, beta-1 receptors on the heart directly affects the sinoatrial node, the pacemaker out of the heart. If you stimulate that, you stimulate your heart rate, increase your contractility, increase your heart rate. Common things that we see as far as neuro complaints that we see with regards to tachycardia. Again, seizures we talked about being postictal. A lot of times, patients in postictal state they're pretty tachycardic. Stroke patients, bleeds, head bleeds, traumatic brain injuries, and even just pain, right? Pain could cause, tachycardia because again, you're activating that sympathetic nervous system, that fight or flight response. So the hows and the whys of the nervous system and how it affects your heart rate and tachycardia. So there's three mechanisms in which it does it, right? So there's reentry tachycardia, and we'll talk about that later on down the road. That's like your SVTs and all that, right? It's a closed loop circuit. So you get this PVC or this extra heartbeat that boom happens, and now you have two separate circuits going down to that AV node, and it creates this endless loop, right? And then we have to intervene. We give them adenosine, we give them some kind of AV nodal blocking agent, and it stops that endless loop, right? Until that happens, or a vagal response could stop it too. Until that happens, you get this perpetuation of that same heartbeat, and the tachycardia continues. What causes that? Again, electrolyte disturbances, some people with certain genetic disorders, especially that affect their sodium and calcium channels, or any structural abnormalities like patients with cardiomyopathies, right? End stage heart failure. And then you got enhanced automaticity. So this is somebody had a heart attack, right? Part of the heart muscle is dead, right? Each heart muscle cell has the potential to be its own pacemaker. So now the dead area, right, not doing its job, especially if they had inferior MI, right, knocks out their native pacemaker. Now, other areas of the heart compete to make that to create that heart rate, And then you have this erratic activity, aka atrial fibrillation, right? Which you love with AFib. And then triggered activity. These are, again, sometimes people have certain genetic disorders, right, in their sodium or their calcium ion channels and their myocytes. So you get this huge influx of calcium and waves of contractility, waves of depolarization, right? And then you develop the tachycardia. And we see it a lot with torsades, right? And that's what we see the waves of depolarization. So endocrine causes, most common cause, hyperthyroids or Graves' disease. You can see this patient with exophthalmos on the top, or maybe she's just scared. I don't know, right? But again, they have this increase in your thyroid hormone. That increase in the thyroid hormone directly is related to our sympathetic nervous system. You get that overstimulation, that fight or flight response. You get the tachycardia. Pheochromocytomas, again, not as common, usually more common in males than in females, right? And it's a tumor that's formed on the adrenal gland, and it spits out extra catecholamines, right? So it stimulates those beta-1 receptors out of the heart. You guys get called on these ones, right? Common things that you guys get called on these ones: headache, syncope, right? Especially younger males, right? More so than females, with no other prior medical history. A lot of times, you guys are their first encounter with this. But the most common thing that you guys see would be headache, syncope. Then you show up, they're tachycardic, they're sweating, they're hypertensive, right? Now, you're not going to make the diagnosis of pheochromocytoma. If you did, you look pretty cool, right? But again, it's something to kind of keep in mind, because these patients, if they're in that catecholamine storm, right, with hypertension, tachycardia, right, they could develop, they could quickly deteriorate high output cardiac failure. And then you got a problem, right? So then that's we talked about that anticipation of badness. And obviously with endocrine, diabetes, any kind of change in your euglycemic state, your body responds with tachycardia, right? It's either hypo or hyperglycemia. Pulmonary causes, PEs, right? So tachycardia is the most common vital sign abnormality, more so than hypoxia when it comes to PEs, right? So the first thing that you normally see is that tachycardia. And why is that? So the lungs normally are a low pressure system. Your right heart pumps blood to the lungs, right? Your right heart is built to pump against a low pressure system. Now you put a clot in that system, bumps up the pressure in that system. You have this pump that's not used to pumping against that. It has to try to overcome that, so it increases the heart rate. So they become tachycardic. Again, independent. So tachycardia is an independent risk factor. So for poor prognosis for PE. COPDers see a lot of that, especially with their exacerbations. Their most common cardiac dysrhythmia, tachydysrhythmia, multifocal atrial tachycardia. I got a picture of that later. You guys are going to love it. COPD flares, the reason why they get tachycardic is because they become more and more hypoxic. So they get more and more hypoxic. That ventilation perfusion ratio that we see is distorted, right? So they're getting perfusion, but they're not ventilating well because of that inflammatory process in the lungs, right? So then the heart rate tries to compensate by increasing the heart rate. Again, it's all about cardiac output. S1 Q3 T3 pattern. So I put this on here. So it's only found in about 30% of PE patients, right? It's one of the things that you'll see on a test or any kind of EKG test that you're taking. It's a good indicator of right heart strain. So remember, we talked about, again, pulmonary area, the lungs, low pressure system, right heart's built to pump against a low pressure system. You put a clot in there, or you have COPD that raises that pressure up. Now you have a heart that's not used to pumping against a high pressure system. So you have right heart strain, right? And in right heart strain, you see S waves in lead 1, Q waves in lead 3, and then inverted T wave in lead 3, S1, Q3, T3. So again, only 30% of the time you can see it in PEs, but it's a marker of right heart strain. So a lot of stuff could cause right heart strain, right? So pneumothorax is called right heart strain, right? So again, something to kind of look out for. Again, you're going to nail it home. It's all about what we care about is what the heart spits out. What we care about is what the heart is. The heart meaning it's the metabolic demands out of the body. That's directly related to our heart rate. Again, tachycardia and stroke volume. So what affects stroke volume then? right? So you got preload, afterload, and contractility. So what's feeding into the pump, what's pushing against the pump, and the pump itself is, or how healthy the pump is itself, right? So what affects preload? So they're hypovolemic, either from trauma, right? Sepsis, right? Dehydration. You get that decreased venous return, you're going to drop your stroke volume because there's not that much stuff going into the pump, right? So afterload, we talked about the PE and pulmonary hypertension, again, causing that strain on the pump for the pump trying to get that stroke volume out. Again, poorly controlled hypertension, patients that haven't taken their blood pressure medications in years. Again, that or valvular abnormalities as well. We'll talk about that later. And then the pump itself, right? So cardiomyopathy, CHF, people who've had an MI, they're in cardiogenic shock, infectious processes. We see young people with myocarditis, right? Especially in the viral season, we see a lot of viral myocarditis. Again, something that affects the pump itself, affects that stroke volume. So how does the heart compensate? So if your stroke volume drops, right, you got to raise the heart rate to maintain that same cardiac output, right? That's all it is, right? So it's all about what we care about is what that heart spits out. So pericarditis, so inflammatory causes. So you got pericarditis and myocarditis. Pericarditis is just inflammation of the sac around the heart, right? Again, viral infections is usually number one cause, right? And then myocarditis is actually infection or inflammation of the heart muscle cells themselves, right? People with pericarditis, again, usually younger, it's more pleuritic chest pain, so sharp stabbing, shooting, burning, electrical pain. They say worse when I lay down, better when I sit up, and the reason why is when you're laying down, that inflamed sac is pushing against the anterior portion of the vertebral column, causing more pain, right? Myocytes aren't affected because it's not part of the heart. It's just the sac around the heart. Then you deal with myocarditis, and now you have the cells themselves become necrotic. They start to die off, right? Again, most common causes is infection, but again, certain chemo drugs could cause myocarditis. You know, methamphetamine. You know, we are in Mesa, right? So methamphetamine capital of the world here, guys, right? You know, you can tell that from my time at Desert. But again, cocaine, not so much. We don't see so much cocaine here. You know, maybe if we're up in Scottsdale, a different story, right? Paradise Valley, different story. But down here in Mesa, we're more meth, right? But those sympathomimetics, again, that could cause myocarditis. And the big thing that we see with both of these is you have this tachycardia, right? Either from the pain, right, or just from the decreased cardiac output. But you also have this diffuse ST changes, either depression or elevation, that doesn't match the anatomical distribution that you'd see with an MI, right? So inferior MI, you see ST elevation 2-3 AVF, anterior CV1 through V4, right? This one you see diffuse everywhere, right? Because the whole heart's affected, right? It's not just part of the heart. So again, that's a big thing with the myocarditis and pericarditis. So valves, right? So aortic stenosis, right? Aortic regurg, mitral stenosis, and mitral regurg. So aortic stenosis, again, aortic valve, anything that causes inflammation or stiffening of that valve, right? You're going to increase the afterload. Therefore, you're decreasing that stroke volume. You're decreasing that amount of stuff that's being pushed out against the heart. Heart rate responds by increasing the heart rate. Regurg, again, regurg, so the aortic valve becomes floppy. Blood starts to pull back into that left ventricle, dilates the left ventricle. The heart is trying to compensate, so the heart rate's going to increase because it wants to get that stuff out of there, right? It wants to empty that chamber as fast as it can because it's too dilated, right? So that's where you'll see that. Mitral stenosis, again, usually happens post-traumatic fever. That left atrium becomes stretched because it's pushing against the stenotic stiffened valve, right? Left atrium stretches, leads to atrial fibrillation. One of the leading causes for atrial fibrillation is that stretching of the left atrium. Mitral regurg, again, most common worldwide as far as the valvular disorders, usually happens with age. Where you guys worry about that, right? Again, if it's an acute mitral regurg, and it's tough to hear murmurs, right? It's tough to hear murmurs in a nice, quiet hospital room, let alone someone's family room with the TV blaring or the back of an ambulance, right? But in the setting of an MI or a person who's having symptoms that are consistent with an MI, EKG shows evidence of an MI. If you do hear a murmur, right, a lot of times that's usually from injury to those muscles that open and close the valve, the mitral valve, causes that regurgitation. they get backup of blood into the lungs, right? Pulmonary edema, right? So that's what we see with acute mitral regurg. So we talked about cardiomyopathy. So dilated cardiomyopathy or hypertrophic cardiomyopathy, there's different flavors of that. Very, very common. Again, 6.5 million people in the U.S. live with heart failure, right? So again, what is it? Just basically the heart isn't meeting the demands of the body, right? Any kind of acute decompensation, you're going to decrease that stroke volume for whatever reason. Heart rate tries to compensate by increasing the heart rate. Again, cardiac output, heart rate times stroke volume. Beware of beta blockers, because a lot of these people with CHF or cardiomyopathies, we got them on beta blockers, right? And they can't mount that response, right? So now they go into a heart failure, and normally, so the heart's like, oh, all right, we're dropping our stroke volume, we got to bump up our heart rate, but it can't because we block their beta receptors, right? So again, very, 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 very common, especially in the elderly population. All right, so what else could cause it, right? Again, we talked about pain. Anytime you activate that fight or flight response, that sympathetic nervous system, right? Pain, headaches, anxiety, stimulants. Again, we are in Mesa, right? That's probably the corner of Stapley and Broadway right there. Opioids and alcohol withdrawal, right? Again, we see a lot of that just with the fentanyl crisis that we're dealing with, but also certain medications, just albuterol. So you got asthmatics, right? Again, they've been having an acute asthma attack. They're puffing on their albuterol inhaler. They come in there and they're attacking away. A lot of different drugs could cause it. Again, some of this, the key thing about that is try to get your best history. Try to get, again, if they usually have that Tupperware box, or they got like a shopping bag full of meds, just grab it, take it with you, bring it to us, let us go through it, right? But the best thing that you could do is just gather that information, right? Because a lot of times these people are really poor historians. They can't even pronounce half the name of the medications that they're on, let alone tell us if they've been taking them or not, right? So if you guys could grab the medications, we'll go through it, we'll look it over. But again, just a lot of different medications could cause tachycardia. So oxygen carrying capacity. So again, it's the amount of blood or amount of oxygen that's bound to hemoglobin. It's the amount of oxygen that's dissolved in the blood, right? When you decrease that oxygen content, right, you're not getting the adequate oxygenation, become hypoxic, the heart rate responds by tachycardia. Again, not so good, good. Not so good color, better color, right? So again, what are the causes of that? Again, most commonly low hemoglobin. It could be acute from bleeding, right? Or chronic. And again, a lot of our renal patients are chronically anemic, right? They live with a hemoglobin of like 7 to 7.5. With you guys, I'd transfuse blood on you guys in that situation, but they've adapted to it, right? But the problem is any subtle change with them could cause pretty significant clinical changes, right? So again, how the body responds, low oxygen content, and increases the heart rate. Carbon monoxide poisoning, again, we talked about pulmonary disease, asthmatics, COPDers, PEs. Again, the big thing here, getting that history, patient presentation, again, documentation. So sinus tachycardia, most common syndrome, is not a dysrhythmia. So sinus tachycardia is just your body's responding to something, right? Something's happening to your body, and your body's responding by increasing the heart rate. So it's not considered a dysrhythmia. And a lot of times, we don't want to try to stop that. We want to try to find out, well, what's caused this in the first place, right? In your life, we worry about just vital signs, right? So again, if they're hypoxic, give them oxygen. If they're hypotensive, give them some fluid, right? If they're in pain, treat their pain, right? But the big thing here for us, a lot of times people look at numbers, right? And they want to treat the number and not the patient, right? But you want to do the opposite. You want to deal with what's going on. And sometimes this is a good thing, right? The body's, again, remember, cardiac output, heart rate times stroke volume. So POTS. POTS is very common, especially in the younger population, right? About 1 to 3 million people have that in the U.S. So POTS is, and it's postural orthostatic tachycardia syndrome. So a lot of times people think that it's like orthostatic hypotension, two different ball games, okay? So POTS is just the heart rate, right? So they change position, right? and their heart rate increases by about 30 beats per minute, but usually their blood pressure is not affected, right? The symptoms, again, what you guys get called for is primarily syncope or dizziness or pre-syncope, right? Again, young females greater than males, situation where they have change, they have syncope or near syncope upon standing. But again, not necessarily blood pressure involved. It's just a tachycardia. And if it becomes symptomatic, they get sent to a cardiologist and they can put on some medications for it. So AFib, very, very common. We talked about some of the causes. Again, that dilated left atrium, 33.5 million people with AFib. Independent risk factor for a stroke. So people who are on AFib, they either got to be anticoagulated, right, or we got to control that AFib. Because if you're in chronic AFib, rather than those two chambers squeezing, they're quivering. While they're quivering, clots are forming, right? Those clots form to they get a stroke. So independent risk factor for a stroke. Typical rate, atrial rate is 300, but the AV node, because refractory period, slows it down. Again, the big thing here is determining how long have they been in AFib, right? And usually they're pretty symptomatic. They complain, chest pain, shortness of breath. They don't feel well. They feel pre-syncope. If it's acute AFib, right? A lot of times we try to cardiovert them to get them out of it, right? Because you don't want them sitting in AFib, right? Unless they're older and they failed cardioversion, right? So, but especially if they're a younger person in atrial fibrillation, we always try to get them out of it, right? But we got to be careful, right? So again, if they've been in AFib for more than 48 hours, now you've given those atria a chance to kind of develop some clots in there. You shock them out of it. Now they go into sinus rhythm. Now you gave them a stroke, and now they're calling Goldberg and Osborne, right? We don't want that. So again, the big thing here is finding out, when do the symptoms start? That's a big thing for me when I see a person in AFib, especially if they didn't know that they're in AFib. Flutter, again, flutter, we see a lot more with that with our COPD patients. Again, it's that when we talk about that reentry, so that constant loop that's kind of going through that AV node, right? And that's where you're getting these flutter waves. The 2-to-1 AV block, so 2-to-1 flutter, right? A lot of times it could look like sinus tach, but they have that sensation. The patient will tell you that sensation that's consistent with like AFib. I feel fluttering in my chest. I feel palpitations. Things don't feel right. It feels irregular. Usually I'll have them vagal, right? And while they vagal, that'll help kind of slow things down. And then I could kind of see the flutter waves, right? So something to kind of think about. But again, the big thing here is just kind of recognizing that and understanding that this is something that we may need to get them out of that. But you got to be careful as far as how long they've been in atrial flutter. Usually this is more acute than AFib. So MFAT, multifocal atrial tachycardia, we see that mostly in COPDers, but we also see it in CHF, chronic renal failure patients. And really it's just, again, when you look at the rhythm strip, you'll see P waves. You have to have 3 or more different morphologies or appearances to the P waves to diagnose it. The arrhythmia usually abates or goes away once you treat the underlying problem, right? So if COPD flare up, you treat the COPD flare up. CHF exacerbation, treat the CHF. Chronic renal failure patient has missed dialysis for the past 2.5 weeks, get them dialyzed, right? So usually that helps treat this arrhythmia. I can't take credit for this animation, but I thought it was pretty cool. The thing, I would not know the first thing how to do that, but I'm sure some of you guys do. AV nodal reentry tachycardia, one of the most common things, SVT, right? We see it, we know it. We've probably seen like 3 or 4 cases per week on this stuff, right? So it's an accessory pathway that occurs within that AV node, right? And then you get these tachycardic episodes, 160s to 220s. Most common complaint of palpitations amongst people with young, healthy hearts, right? Again, we always know about the EKG characteristics. You don't see a P wave. And that treatment approach, aka adenosine or vagal maneuvers, right, is to disrupt that loop within the AV node itself. Compared to AV reentry tachycardia, so this is when you have a separate pathway different from the AV node itself, right? So you got the AV node, and then you got something by it, right? That they're both competing for electrical activity to go through to the ventricles, right? Most common is the orthodromic. So again, the orthodromic on the left here. So the impulse goes from SA node to the AV node. it goes down to the His-Purkinje system, but then it comes back up through that accessory pathway, and you get this constant loop, right? Less common is the antidromic, where it goes from the SA node to the AV node, and rather than go through the AV node, it goes down through that pathway. How you tell the difference, right? And in your cases, it does make a difference, right? In your cases, you really look at the QRS complex. Is it narrow? Is it wide, right? For orthodromic, right? Again, it's more narrow because it's going through the AV node first. Antidromic is more wide because it's going through this accessory pathway. Again, the big thing that we worry about in these, and we'll talk about this later, is if we start messing around with that AV node, right, with drugs, right, to try to block that AV node, now that electrical activity could go through this accessory pathway that has really no refractory period, and then you have these heart rates that could be up in the 300s, right? So that, not a good thing. VTAC, we've seen it, right? The thing that we get worried about with VTAC, and it's more, again, you guys, it shouldn't worry you guys because we see it, we treat it. Wide complex monomorphic tachycardia, you got the algorithm, you know how to treat it, right? My world, right, when I call the cardiologist, they come back with, what is it, SVT with the aberrancy or is it VTAC? I'm like, I don't know, buddy. All right, but the guy's alive, okay? We shocked him. He's on amiodarone. Do your thing, okay? All right. The big thing with argues against is it likely VTAC versus SVT with aberrancy. Usually SVT with aberrancy, you have some kind of underlying bone branch block morphology. QRS is a little bit wider in VTAC at 160. Again, with VTAC, the typical AV dissociation, Ps aren't communicating with QRSs, if you can even see a P. Underlying structural heart disease, prior MIs, these are sick hearts, right, that usually go into VTAC. Again, with you guys in your world, right, you treat it the same. Wide complex monomorphic tachycardia, we got our algorithms we treat. It's just something that we see with VTAC versus SVT with aberrancy. We all know what that is, right? So VFib, right? Most commonly post-MI, right? You could have electrolyte abnormalities that we see with that, especially hypomag, right? So alcoholics and hypomag. Alcoholics are notoriously low in their magnesium, right? So an alcoholic that is seen found down, right? You find them in VFib, right? Again, you go on your algorithm for VFib, right? But a lot of times we see, like, if we bring them back, we get our labs, their mag is horribly low, we give them mag and it usually helps them, right? Underlying cardiomyopathy, we all know about commotio cordis. What's the guy's name from the Bills? Demarius? There you go, yeah. So commotio cordis, so you get this blunt force trauma to the heart right at the split second where the ventricles are in depolarization. Talk about bad luck, you know what I mean? Poor guy, right? But that's it. That's it. Just literally split second, right? Perfect timing, right? So again, you see this as sporting events, right? So especially guys get called out to, again, in any kind, high school or whatever. So sudden collapse, right? Always think commotio cordis. You can't let them stay in VTAC, guys, right? Because if you let them stay in VTAC, the VTAC goes to VFib, VFib goes to death, right? So we got to do something about the VTAC. Electrical storm. So this is something that I've encountered a few times in the ER, a couple times recently, right? So again, it's if they've had 3 or more episodes of VTAC or shocks from their AICD in a 24-hour period. Where I've seen it is a person who's in persistent VTAC despite multiple shocks, despite amiodarone. I've even tried lidocaine on these patients, right? And they just get to the point where, again, you can't keep shocking somebody 20, 30 times. You keep shocking them, what's going to happen is you're going to deplete their cells ATP or the energy source for those cells. So you got to do something about it. And there's different ways that we could approach this. We could do double sequential external defibrillation. That's been proven to help with electrical storm. So again, VTAC refractory to your normal treatment algorithms, right, is electrical storm by definition for you guys. So you got a couple options, right? You do double sequential external defibrillation, right, or overdrive pacing. So overdrive pacing, this helped in these both last 2 times for me, right? So you shock them to the point, and it takes some timing. You shock them to the point where at least you get them out of that VTAC, and they may only have a couple beats, like a sinus beat, and they go back into VTAC, right? But if you could catch it at that, if you catch them when they're in those sinus beats and then crank the pacemaker up to like 100 beats a minute and overdrive pace them out of that situation, a lot of times you could get them out of that electrical storm. And that's worked for me the past couple times, right? So again, it's a timing thing, right? And you look really cool doing it too, right? So you definitely get some pats on the back for it, right? But if you get them, even you catch 1 or 2 beats out of that VTAC episode, overdrive pace and set that rate to 100, 120, externally pace them, a lot of times you could get them out of that electrical storm. PVCs, we see a lot of PVCs, right? And thankfully, PVCs are, for the most part, benign processes, right? So PVC is just, you had this extra beat that was not generated by the SA node, generated by the His-Purkinje system. Its beat gets generated retrograde to the normal depolarization of the heart. What happens is you have this compensatory pause. So you have the extra beat, the regular beat, the pause, right? People feel the pause. That's what they feel. They say, I feel like my heart stopped. I feel like my heart's jumping in my throat or flip-flopping. And again, there's different flavors to PVCs. You got doublets or triplets. I'll show you some pictures in a couple slides. You got bigeminy, where every other beat is a PVC. Trigeminy, every third beat is a PVC. We see that people who have like a lot of caffeine, stimulants. I see a lot of students that get this because half the ASU population, MCC population, right, they're all on Adderall, right? They say, I swear I have ADHD. No, you just want to study more and you want to party and have a good time. Cool, I get it, right? But that's why you're having PVCs, right? So again, very common with different stimulants. Again, we talked about electrolyte disturbances, low potassium, low magnesium, high calcium. Again, could cause these extra PVCs, and also sleep deprivation too. Just that insomnia or what have you. Again, very, very common. 1 to 4% of the U.S. population will have some kind of complaint of PVC lifetime. Risk factors, again, older age, females. Again, we talked about electrolytes. Sometimes people with underlying bundle branch blocks or ischemic heart disease can be predisposed to PVCs. That's a good picture of bigeminy. Again, every other beat, PVC. When do you treat it, right? So you treat it if it's symptomatic, right? Or if you're seeing any vital sign abnormality. So sometimes hypoxia could cause it. For hypoxic, give them oxygen. They look dehydrated. There's waste management open or whatever. They've been out in the sun all day at the lake, whatever, right? Give them some fluids. When we start putting them on medications is if they've been persistently symptomatic, right? Usually our first choice, like diltiazem or calcium channel blockers. Sometimes they do beta blockers. Less common, flecainide or amiodarone. So healthy patients with healthy hearts, the prognosis, if a person has PVCs and they're a healthy person, they have a healthy heart, they have the same prognosis, same life expectancy as the general population that doesn't have PVCs, right? So again, for the most part, PVCs are benign, but when they become symptomatic, it affects quality of life, right? And that's when we intervene, and that's when we take care of it. That being said, if they're having a lot of PVCs, right? So they see the cardiologist, they put them on a Holter monitor, they check them out, and they say, wow, you're having 1,000 beats or more than 1,000 beats this per day. That's got to be uncomfortable. I don't know if you guys have had PVCs before. I get them sometimes. I have one too many Mountain Dews at work, but again, it's uncomfortable, right? So if you're having more than 1,000, usually that's to put them on medication for it. But also, if they're having that severe PVCs, now you run the risk of developing cardiomyopathy in all comers, not just people with underlying structural heart disease. Again, if they have underlying heart disease, frequent PVCs, common PVCs could worsen that left ventricular function. And again, like I said, bigeminy, trigeminy looks cool on the monitor, right? But for the most part, if they have structurally healthy hearts, healthy person, same prognosis as the general population. So this is the one slide on treatment, right? So we have our protocols. Our treatment for tachycardia is pretty straightforward, right? Stable or unstable, wide or narrow, right? That's how I live my life. That's how you should live your lives too. Okay. So if they're unstable, signs of cardiogenic shock, hypotension, altered mental status, right, really short of breath, then they're riding the lightning. Okay, they got to ride the lightning. You got to get them out of it, right? Wide or narrow, again, sends us down to the different treatment algorithms. WPW. Remember we talked about those endless loops or that closed loop circuit tachycardia. So if a person's got WPW, and you can see that when you look on the EKG, you guys all learn this when you're studying EKGs, that delta wave, that slurring of the upslope, the R wave there. And then you give them an AV nodal blocking agent because you're thinking, well, it looks kind of like SVT. I don't know, right? And you block that AV node, right? Now you send all the electricity down that accessory pathway. In emergency medicine, we call that a clean kill, okay? Because now your heart rate just went to like 350, right? And they ain't gonna live with that, right? So if you can, well, obviously if they're tachycardic, you always get the EKG, right? But history is a key component. They mention a history of WPW, or if you see that delta wave, be careful with your AV nodal blocking agents, or else you'll be talking to Goldberg and Osborne. So, noting nodal agents that we have, again, we love adenosine, right? Adenosine is a big one. Beta blockers, right? Another good AV nodal blocking agent. Calcium channels, sometimes DIDs. DIDs is kind of fallen off now. But for the most part, again, our go-to, my go-to is adenosine. I'm thinking it's SVT. I'm going straight for adenosine. Or I try to have them vagal, right? While I'm getting things set up. Not only that the vagal is probably not, I've never really seen a vagal work. I've seen a couple times with peds, right? Not the adult cell, right? But just, it's cool. Let them blow through something while you're getting things set up and, call it a day. So again, treat the patient, not the paper, right? Get your best history. The patient's going to tell you what they got. We just got to ask them. And a lot of times I'm just as guilty. We get kind of caught up in what we're thinking and what we're doing and what we've already trying to our goals of treatment, and we don't ask the right questions, right? So again, a lot of times the patient will tell you that grab that medication bag or box or whatever they got at home, because that helps us anticipate badness. That's why I decided to talk about this. So again, if we anticipate what's going to happen to us, right? Again, thinking about 2 or 3 minutes down the road, 5 minutes down the road, again, it gets us mentally prepared to address those changes, because by the very nature of our job, things change on a minute-to-minute basis. Murphy's Law is always in effect for EMS, always in effect for emergency medicine, right? And again, keep it simple. Follow those protocols. Thanks for hanging in there, guys. Appreciate it.